Thank you for joining us for this video capsule on the impact of COVID-19 on the experiences of immigrant older adults and their families, challenges and recommendations. This video capsule is brought to you by the Center for Research and Expertise in Social Gerontology and the McGill School of Social Work. My name is Shari Brotman, and I'm an associate professor at the McGill School of Social Work and research member of CREGÉS. Immigrant older adults have unique and important stories to share about aging in Canada. They have demonstrated strength and resilience in the face of many challenges throughout their lives. The process of immigration shapes their experiences over the life course and into old age. This is true whether they immigrated in the past as young adults or more recently, and whether they came to Canada as independent class immigrants, refugees, temporary workers, live-in caregivers, or sponsored members of families. Immigrant older adults living in Canada have much to teach us. Despite our rich history of immigration in Canada, we don't know a lot about the impact of immigration on aging members of our communities. Most research about older immigrants tends to group very different people together based upon the region they came from or the language they speak. Country of origin and language are important, but so is gender, family status, citizenship, religion, relationships, work, family roles, living arrangements, and many other aspects of people's identities and lives. Without this information on identity and lived experience, it's difficult to develop policies, programs, and services that are culturally sensitive, accessible, inclusive, and non-discriminatory. In this capsule, we'll be addressing the realities and experiences of older adult immigrants and their families, as highlighted in our recent research project, The Lived Experiences of Aging Immigrants. We will first briefly describe the project and present some socio-demographic data about immigrant older adults in Montreal to help provide some context for understanding the influence of life course realities on the ways in which challenges are produced and reproduced during the COVID-19 pandemic. We will then present some of the issues related to the impact of COVID-19 on older adult immigrants in relation to health and social care services, family care, employment, and housing, and end with some recommendations for policy and practice level change. Our work on the issue of immigration and aging spans 6 years, 2 projects, and 3 provinces: Quebec, Alberta, and British Columbia. The objectives of our project included exploring the lived experiences of immigrant older adults, which pays attention to how older people identify themselves and how they feel about such issues as family, community, belonging, and resilience. Increasing our understanding of the impact of immigration on aging within the context of life histories, and examining the ways in which structural discrimination across the life course shapes interactions with family, community, and formal services. Finally, we sought to develop mechanisms for amplifying the voices of older adult immigrants in the public domain and encouraging knowledge exchange between multiple actors and stakeholders, including older immigrant adults themselves, their families, community-based seniors organizations, immigrant serving organizations, service providers, and policymakers. We used 2 theoretical ideas to frame our study: intersectionality and the critical life course, to help us understand people's unique life stories and the ways in which barriers and discrimination might operate in their daily lives. The critical life course pays attention to sequences and consequences of meaningful life events and how they are organized, connected, and evaluated. An intersectionality framework acknowledges the existence of distinct but inseparable categories of oppression which inform individual identities. The voices of marginalized people are central to the inquiry, and individual experiences of marginalization and resilience are interpreted within the context of structural inequality. In the first study, we spoke to 19 older adults from Quebec and British Columbia who immigrated at different times and under different programs. During 3 interviews with each participant, We spoke about their journeys and experiences, explored the ways in which encounters with institutions, programs, and policies across the life course shaped interactions with family, community, and formal services, and gave them cameras to take pictures of their daily lives. We presented both their challenges, such as barriers and discrimination, poverty and family disruption, and celebrations, such as building community, caring for others in the family, contributing to society, faith, and resilience. This narrative photo voice project is a testament to the strength, resilience, and determination of every immigrant we interviewed. Their stories highlight how policies and services need to be more supportive, flexible, and accessible. We showcase many of their photographs in this video capsule. A photo voice exhibit showcasing the stories and photos of our participants was held simultaneously in Montreal and Vancouver in 2017. Following this, we expanded our team to undertake the second project, and between 2018 and 2019, we organized a series of stakeholder outreach forums in 4 regions across Canada: Greater Montreal, Quebec City, Calgary, and Greater Vancouver, in collaboration with local community partners. These outreach forums brought together stakeholders from multiple sectors to share information and strategize about the actions necessary to improve recognition and support for aging immigrants. So let's look briefly at a snapshot of the socio-demographic characteristics of immigrant older adults. We will use Montreal to situate this data locally. Over 2/5 of older adults living in Montreal were born outside of Canada. This represents 44% of all older adults in Montreal. Older adult immigrants came to Canada under different immigration programs and categories, which include economic and independent class, family sponsorship and super visa programs, temporary foreign worker, domestic, and live-in caregiver programs, refugee claimants, as well as those who are undocumented and therefore have no status in Canada. The vast majority of adult immigrants aged in place, with 96% of older adults arriving prior to 2006. The vast majority of immigrants who arrived to Montreal as older adults, that is 65 years of age or older, came via the Family Reunification Program. There has been a recent increase in family reunification after a slowdown for several years due to changing government priorities, although the entry program used for family reunification is shifting, with the government expanding and emphasizing the parent and grandparent super visa as a means of entry, rather than the family sponsorship program, which is by design a more permanent entry to Canada. The super visa is an extended multiple entry visitor's visa, which allows the individual to stay for a maximum of 2 years in Canada before being required to leave the country. The super visa lasts for a period of 10 years, so that the older adults can come and go over a 10-year period without needing to apply again, as long as certain conditions remain intact, such as proof of adequate annual income on the part of the sponsoring family and proof of private health insurance. Stricter criteria are in place for the super visa when compared with other visitors' visa, and host families must pre-purchase private medical insurance before the arrival of their parent or grandparent. Research has found that racialized older adults are overrepresented as applicants requiring a travel visa, but underrepresented among those accepted. Acceptance rates are lower for those from African, Asian, and Middle Eastern countries when compared with those from the US and Europe, pointing to the continued racial bias in decision-making on the part of government. 14% of all immigrants aged 65 and over speak neither French nor English, and the rate of knowledge of English or French decreases with advancing age, with 27% of those 85 plus speaking neither language. 44% of those who arrived in 2006 or later speak neither English nor French. It's important to consider financial precarity among older adult immigrants. They actually have the lowest annual income when compared to all older adults and all immigrants, regardless of age. To highlight this issue of living in poverty, Statistics Canada reported that just over 27% of all older immigrants spend more than 30% of their income on housing, a rate which indicates the potential for financial precarity. Recent immigrants and non-permanent residents are in more challenging circumstances, with 22% and 24%, respectively, spending more than 50% on housing. For comparison purposes, only 7.5% of all older adults generally spend more than 50% on housing. This indicates a great concern regarding poverty amongst older immigrants who have recently arrived or who are non-permanent residents. 27% of older adult immigrants live alone, and they've been identified as being at high risk for social isolation and loneliness, which can create concerns about health and well-being, both mental and physical. Women live alone at a higher rate than men. The National Advisory Council on Aging has recently declared older immigrants as being at significant risk for social isolation, particularly those who are recently arrived and refugees. According to a recent study published in 2016, older adult immigrants live with family in multi-generational homes at almost 3 times the rate of Canadian-born older adults. The rate of intergenerational cohabitation amongst immigrants, at 29%, is growing steadily and is an important survival strategy for these families, both in terms of financial survival and in relation to enacting resilience and solidarity within families. The conditions under which immigrant families cohabitate will be considered shortly. And finally, in a study published by L'Appui in 2013, it was reported that 32% of family caregivers to older adults in Montreal were immigrants. Keeping all this data in mind, let us now turn to the impact of COVID-19 on immigrant older adults and their families. To begin, it's really important to emphasize that most challenges that will be presented today predate the pandemic, but are significantly exacerbated by it. In terms of health status, the research literature has for a long time pointed to the impact of social inequality on the health and well-being of older racialized and immigrant people in our society. Health inequities resulting from the interrelated factors of racism and other forms of discrimination and poverty are significant amongst older adult immigrants, and this can lead to negative health outcomes. Poverty and minority stress contribute to higher rates of morbidity and mortality among racialized and immigrant population. So, for example, this results in a lack of access to affordable and safe housing, overcrowded, unhealthy living conditions, lack of ability to purchase healthy foods, an inability to pay the costs for insurance, medicines, and medical treatments stemming from poverty and inequality, as well as issues of discrimination in employment, which all contribute to ill health, particularly as people age. I would be remiss if I didn't also point to the reality of non-recognition of educational attainment in other parts of the world by Canadian employers and government as contributing to social and economic inequality. By forcing immigrants to work in low-paying and often unsafe employment and requiring them to work multiple jobs and/or long hours to make ends meet. Many immigrants, older adults in particular, have reduced access to pension entitlements because they do not meet the requirement of working at least 10 years in Canada in order to qualify for a government pension. The literature speaks to the concept of early aging to describe the process of morbidity and mortality within marginalized communities, including immigrant communities. In fact, the protective factors that have led to what is described as the healthy immigrant effect, whereby newly arrived immigrants are initially healthier than the Canadian population. And this because healthier individuals are considered more desirable for immigration under the current application system. This actually wears off within about 20 years because of precarious living and working conditions, the stress of living with daily acts of racism and discrimination, non-recognition of education, and weakened extended family and community ties due to migration. Early aging means that immigrant and racialized older adults experience higher rates of chronic health conditions such as diabetes, heart disease, and dementia, and are diagnosed with chronic illness at an earlier age than the general population. We know that in the current context of COVID-19, pre-existing conditions are a significant factor in increasing the risk for negative outcomes, a fact that puts immigrant older adults aged 50 and over at considerable risk, especially when they continue to need to work in order to support themselves and their families. In addition, social isolation, as I mentioned in the previous slide, and a lack of support can really increase one's risk of negative consequences to health and well-being, both physical and psychological. Being alone may result in delayed help seeking, which is of crucial concern in the context of COVID-19, where receiving a prompt diagnosis and treatment where necessary is crucial. Without someone having eyes on you, you might suffer for longer until symptoms require an emergency response. This is a potentially problematic scenario in the case of COVID-19. Social isolation can be exacerbated for immigrants because of a loss of social networks, which occur due to family and community disruption resulting from immigration. Older adults who immigrated to Canada and who left behind extended family and community relationships continue to rely on those relationships either by phone or also, when financially possible, by visiting the home country. Transnational relationships are important to many older adults who may go home to visit friends and family during, for example, the winter months in order to sustain relationships and well-being. During the pandemic, as we know, travel is impossible or highly unlikely. There are some issues which result from immigration criteria as well. The most notable is the family sponsorship and super visa programs, which require the sponsoring family to pay out of pocket for healthcare insurance and health services over a 10-year period. This may have a negative impact on access to healthcare, with paying for necessary medical care creating significant burden on older adults and their families. Finally, accessing health services among undocumented older adults is highly problematic. These older adults have little to no access to barrier-free, affordable health care, and we're actually seeing an increase in the number of undocumented older adults in Canadian society. Interpretation or translation in hospitals, home care, and long-term care services is a considerably problematic issue in our healthcare system and has been so for decades, and so is typically called upon only as a last resort. Instead, families are overwhelmingly required to act as interpreters, or sometimes volunteers from the community take this on. As well, staff who speak the patient's language may be called upon to interpret, regardless of whether or not this is part of their job description. But because of social distancing measures that restrict family or volunteers from entering sites, and the reality that ethnocultural staff that speak different languages have been redeployed or are overburdened with work at this time, and movement between hot and cold zones is restricted, we find that there are more older adult immigrants who speak neither English nor French, who are unable to communicate even their most basic needs with staff. Finally, racism and discrimination are issues which, of course, predate the pandemic, but are made worse during the pandemic. This includes exclusion, lack of attention to accessibility barriers, and lack of development of cultural safety services and protocols. The impact of these include a mistrust in the healthcare system by older adult immigrants and can contribute to delayed help seeking as a strategy of protection against discrimination. So as a result, as stated previously, people within marginalized communities, like older adult immigrants, may arrive at the doctor's office later in an advanced state of illness, which may compromise health outcomes. Now to employment challenges. Many immigrants and their families live in poverty, and so as they age, must continue to contribute to family survival, both locally and transnationally, by working, often in the secondary labor market and under the table, where the pay is low and there are few labor rights. Currently, during the pandemic, we must also be concerned about the level of adherence to safety protocols in these types of settings. Thus, the pandemic brings to the fore not only health issues, but also those of workplace inequality. And finally, we must consider the loss of employment with no recourse to employment insurance as an issue contributing to financial crisis, particularly for older adult immigrants and their families. In addition, it's important to mention that there is a high representation of immigrants generally among frontline healthcare, both in the public and private sector. This includes personal support work, nursing and support staff in acute care, long-term care, and home care settings, as well as private domestic labor, where older adults are at possible risk of exposure to COVID-19. Many older adult immigrants continue to work or return to the workforce after retirement in order to support themselves and their families. Workplace safety, rights, compensation, and conditions facing older adult immigrants in the workplace are urgent policy issues. The issue of family survival and family solidarity is also important to consider. Grandparents, for example, are an important resource to the family system and often provide childcare to grandchildren. With school closures and other family stress at this time, the role of older adult immigrants in childcare is on the rise. Intergenerational transmission of COVID-19 is a concern for older adults and those with chronic health conditions. I remember seeing on the news recently a politician in his daily reporting saying, "Don't let the grandparents watch the children." This statement reflects race and class bias and a total lack of understanding of the issues facing immigrant families. Because many immigrant families face economic hardship, particularly those that have more recently arrived, the possibility of arranging other forms of childcare aside from grandparents when both parents are working and doing so over long hours in the secondary labor market, well, it's impossible. Government must be made to be more responsive in acknowledging the reality of intergenerational family care among immigrant families during the pandemic. Currently, these families have no options. Older immigrant spousal caregivers are also under increased strain at this time as a result of closure or limitations in home care services due to the pandemic. In addition, many multi-generational households lack space to self-isolate. Remember, almost a third of older adult immigrants live in multi-generational family households, and this rate is increasing steadily. Given the high rate of poverty, many must share spaces in small apartments. There are few low-cost housing units large enough to enable families to cohabitate safely. And finally, it's really important to reiterate that there's a big assumption in the healthcare system generally about the presence of family members to provide care to older adults. There's a belief that ethnocultural minority families take care of their own and that we don't have to worry about servicing these families as much because they're cared for so well by spouses, children, and grandchildren. So issues of access and equity to, for example, home care can often be put on the back burner. These are assumptions that do not stand up to scrutiny. Research has pointed to the economic and social strain on families that limit their capacity to care for aging members, and that resistance to receiving formal services is based more upon concerns regarding exposure to discrimination rather than simply a personal choice to avoid it in favor of family care. And so we have to be careful not to let this assumption lead us to neglect the very real needs for culturally safe and relevant care free from discrimination. Social and low-income housing that does exist is in dire need of repair, and there are very few adaptations for people with disabilities. So this general issue that predates COVID-19 contributes to increased risk because of COVID-19. Overcrowded, unhealthy environments of disrepair are a danger to public health. Finally, gentrification plays a part in the increased risk to health and well-being among older adult immigrants. As a result of gentrification, older adults may end up being forced out of their low-cost apartments and required to find accommodation and housing which are far from their culturally specific and familiar community-based resources and support. Culturally relevant services and trusted relationships with familiar neighbors, friends, and supporters are crucial. Doing without them can damage already fragile health and well-being. This includes the local pharmacist who speaks your language, the local grocer who sells your food, the teller in the bank that knows you very well as the social clubs and spaces of worship that you frequent. Finally, we turn to some recommendations. First, there needs to be an increase in direct financial support to immigrant older adults and their families. The amount of financial support that has been given to older adults by government is not enough for anybody, let alone people that are living in poverty. We need to provide free or very low-cost personal protective equipment. This is very important, especially in consideration of multi-generational households to reduce exposure to risk, as well as attend to those older adult immigrants who are engaged in domestic labor and within the secondary labor market, where adherence to regulations may not be strictly followed. Asking older adults to bear the cost for this protection is unjust and unfair. Within the public healthcare system, we need to engage more system navigators, translators, and interpreters to help older adult immigrants negotiate and navigate the system. It's very complex for all of us, and when you don't speak the language, it's next to impossible. This includes providing information on measures to reduce risk in multiple languages and using different media to reach out to those who have a lower level of literacy, like the radio and TV. L'Alliance des communautés culturelles pour l'égalité dans la santé et services sociaux, CREGÉS, was amongst the organizations involved in the development of documentation in multiple languages funded by government. This was an important beginning, but the government needs to expand funding to ensure the availability of much needed information in multiple languages across sectors. We need to provide telephone support information and guidance in multiple languages as well. That includes public health, hospital, testing centers, and pharmacies. Many older adult immigrants use the pharmacist as a first contact in managing health concerns. So pharmacies need to consider increasing the availability of multiple languages on voicemail and written documentation. We need to prioritize older adult immigrants and their intergenerational households for vaccination, and also consider older adult immigrants that provide much needed support to family members living in long-term care homes, as well as other members of immigrant families. This has not been adequately addressed by government to date. We need to increase the availability of free or low-cost tablets and facility-wide internet in all forms of congregate housing to address social isolation and facilitate interpretation where possible. We must enable older adult residents to reach family and community, both locally and transnationally, at no cost at this time. And we need to include immigration status and other social determinants of health in vulnerability risk assessments, both physical and psychological. We need to increase financial support to community-based agencies and programs that are designed to provide support and reduce social isolation related to COVID-19. They do a great job now with very little money. Much of what they do is volunteer-based, and they need to be better supported. Generally, in terms of employment, government must address older workers' rights and entitlements, with particular attention to the secondary labor market and domestic labor, where many older adult immigrants are working. This includes attention to improved compensation, workplace conditions, access to benefits, and health and safety compliance. We must also consider improving the process and speed for people to gain permanent residency status. We need to provide more support to caring grandparents, not simply say, don't do it. This includes providing personal protective equipment and creating childcare programs. Respite programs must also be enhanced, particularly to those older adult immigrants providing care to other older adults, like spouses and siblings, in the context of home care. We should be suspending sponsorship regulations requiring out-of-pocket payments and co-payments for health services by family members during the pandemic. A hospitalization and/or ICU admission can lead to huge expenses for those with no or little medical insurance. Even with medical insurance, co-payments can be expensive and put low-income families at further risk. This is even more true for undocumented older adults. In terms of housing, we need to repair and replace the current social housing stock and increase it. We must remove barriers related to disability access, as well as make available larger units in order for intergenerational families to live safely. We need to remove barriers for recently arrived temporary or sponsored older adult immigrants to apply for social housing. And we need to provide barrier-free access to transportation because of housing displacement as a result of gentrification. The issue of gentrification must be addressed more globally to reduce the risk of older adult immigrants being pushed out of their familiar neighborhoods. Finally, we must concretely address racism and other interlocking forms of discrimination in policies and programs across multiple sectors. We do this first by recognizing systemic racism exists and then developing plans to address it. This includes both staff and patients or clients. Attention to cultural safety, equity, diversity, and inclusion, and access to care is essential. Equity, diversity, and inclusion policies and strategies, which include attention to immigration and racialization, both during the pandemic and well beyond it, are necessary and of immediate concern. We need to move beyond statements of principle to develop concrete strategies in order to redress racism and other forms of discrimination in the various sectors we have spoken about today. One way to start is by including older adult immigrants themselves, their families, and their communities around the decision-making table. This can begin a process of critical engagement necessary for systemic change to occur. On this slide, we introduce you to our research team over the 6 years. We thank everybody for their hard work and dedication in bringing our project to fruition. On this slide are our local Montreal partners across the 6 years, our advisory group on the first project, as well as the partners for each of the stakeholder outreach forums that were held in Montreal and Laval. A special thank you goes out to Pascual Delgado of Access, who has been our principal project partner in Montreal over the course of 6 years, and who has been central to the success of our work. We would also like to thank our funders, the Social Sciences and Humanities Research Council of Canada, and local funding from the Centre for Research and Expertise in Social Gerontology in Quebec and the Michael Smith Foundation for Health Research in BC. We launched our website on November 23rd, and we highly encourage you to check us out. You can make use of our documents like policy briefs, event reports, and the exhibit catalog in your own work. They are available in both English and French. These are the documents cited in this presentation. Finally, we want to thank you again for joining us for this video capsule on the impact of COVID-19 on older adult immigrants and their families. We hope it will contribute to your work in developing strategies for action. Please check out our website. May you and your loved ones stay well and keep safe during these most uncertain and challenging times. Thank you.